Fetal distress. Fetal distress, also known as non-reassuring fetal status. It is actually a term used to describe when the fetus does not receive adequate amount of oxygen before birth or during birth. Lack of oxygen results in fetal hypoxia and acidosis. In other words, fetal distress is when fetus experiences changes in heart rate, decreased in fetal movement, and signs of oxygen deprivation before or during labor. When we say change in heart rate, it means that the heart rate may be slow, fast, or irregular. A slow heart rate means that heart rate is less than 110 beats per minute, known as fetal bradycardia. A fast heart rate is above 160 beats per minute, known as fetal tachycardia. And irregular means repeated variable deceleration. Oxygen delivery to fetus depend upon 4 factors. First, adequate maternal blood oxygen concentration. So any condition that decreased maternal oxygen concentration will decrease fetal oxygenation supply, like anemia, a condition with low hemoglobin level. Second, it depends upon uterine blood supply. Better the uterus blood flow means better the fetus blood supply. Third, it depends on placental transfer. And fourth, on fetal gas transport. Any disturbance in these factors, singly or in combination, can result in progressive fetal hypoxia and acidosis, coming towards the causing of fetal distress. Anemia, the most prevalent condition seen behind fetal distress, low maternal hemoglobin level, causes a reductions in oxygen delivery to the uterus, placenta, and fetus, results in fetal hypoxia. Second, oligohydramnios, a condition of low amniotic fluid around the fetus, which causes the compression of umbilical cord, causes reduced blood flow to fetus. This condition also causes impaired fetal lungs development. Third condition is pregnancy-induced hypertension or gestational hypertension, which is defined as BP greater than 140 over the 90 millimeters of mercury after 20 weeks of gestation. Hypertension in pregnancy after 20 weeks can be with proteinuria or without proteinuria. If present with proteinuria, it is called preeclampsia, and if present without proteinuria, then it is called pregnancy-induced hypertension. The effect of hypertension is that it reduces placental blood flow and constrict blood vessels in the placental both, results in reduced fetal blood flow and hypoxia. Fourth is the post-term pregnancy, which means birth after 42 weeks of gestation. The word term in pregnancy refers to the length of time baby is carried in womb or uterus. For example, if the baby is born before 37 weeks of gestation, such babies is called preterm. And if born between 37 and 38 weeks, such babies are early term. If born between 39 and 40 weeks, these are called full term. And these babies born with maximum outcomes. And if fetus are born in between 42 weeks, should called late term. And any fetus born beyond 42 weeks are post-term babies. The problem with post-term babies are placental insufficiency, which means insufficient oxygen and nutrient supply to the fetus, macrosomia, meaning larger babies, Meconium aspiration, which means fetus inhale first stool if passed before birth, and cord compression. The fifth cause is meconium-stained amniotic fluid. Meconium is the first stool of fetus, mainly composed of water, digestive enzyme, bile, bilirubin, and small amount of amniotic fluid. Meconium-stained amniotic fluid is the presence of meconium in the amniotic fluid, which happened when the fetus passed stool before birth. And if the baby start breathing and inhale the meconium, such condition is called Meconium aspiration syndrome, which block the fetus airway, leads to fetal distress. Other causes includes placental abnormalities, such as placenta previa and placenta abruption. Placental abruption is the spiration of placenta from the uterus walls before birth, mostly present as vaginal bleeding, while the placenta previa is the attachment of placenta to the lower part of uterus. Normally, it attaches to the upper part. Both these conditions results in many complications, especially during labor. Multiple pregnancies and birth also increase the risk of fetal distress as it increases the fetal demand. Umbilical cord prolapse is a condition when the umbilical cord comes out of the uterus before baby, causing compression of cord between the baby's body and the mother's pelvis, restricting blood flow and oxygen delivery to the fetus. Lastly, the nuchal cord, also cues fetal distress. Nuchal cord is when the umbilical cord is wrapped around the fetus neck. Signs and symptoms. Fetus may show abnormal heart rate, decreased fetal movement, vaginal bleeding most commonly with placenta abruption in previa, and meconium presences in amniotic fluid. Management of fetal distress. Primary management of this condition is intrauterine resuscitation, which aim to improve fetal oxygenation by increasing placental blood flow and oxygenation. Intrauterine resuscitation includes change in mother position to left lateral position, or knee-elbow position. Both these positions reduce inferior vena cava compression by pregnant uterus, therefore improve venous return and maternal cardiac output. Second measure is maternal supplemental oxygen to improve oxygenation. And third is maternal hydration. Up to 1 liter of crystalloid fluid is safe, except in fluid-restricted condition like preeclampsia. Fourth is amnio infusion, which means infusion directly into amniotic fluid to decrease cord compression. Fifth option is tocolysis, which is the use of drugs like terbutaline to delay uterine contraction or labor, for example. In more severe case, fetus delivery is the only treatment, which can be done by assisted delivery or cesarean section. Fetal distress also known as non-reassuring.